Hi everyone, welcome to Medic's Corner. Today we'll be studying the topic pneumothorax. So before I even talk to you about what is pneumothorax, I just want you all to have a look at this quick diagram that looks at our respiratory system. So basically here we have two lobes of the lung and we have some good amount of air flowing into them. Now the thing that you need to be aware about is that a lung has two types of membranes. One of them is called the visceral pleura. So visceral pleura is basically that layer that sticks onto your lungs. So it's in very close proximity with your actual lung. And then we have your outermost layer, which is called the parietal pleura. Normally, there is some good amount of space between the visceral and the parietal pleura, and this is to allow good amount of expansion in your lungs, and that space is called pleural space. Now, when we look at the topic pneumothorax, we need to think about these membranes. So what essentially happens is that there is some kind of disruption to either of these membranes. Now, it can be to the parietal layer or it can be to the visceral layer. So if we look at the parietal layer, what essentially happens is that your outermost layer is damaged, which means your air can go in, but then when it tries to move out, the air causes the parietal pleura to close. As a result, the air is not able to escape. And if we look at the second instance, we're looking at the visceral pleura. So in visceral pleura damage, what basically happens is that your air basically escapes from your lung and it starts to fill up in your pleural space. Now this means that your air is escaping out of your lung, but it doesn't have anywhere else to go. So it basically starts to accumulate in a closed space. So if we look at the two instances that we have, in both cases, what's happening is that there is accumulation of air and there is no escape of air essentially, and this in a way affects your lung expansion and also affects the way you breathe, and this is essentially what a pneumothorax is. The next thing that we're going to have a look at is types of pneumothorax. Now there are two types of pneumothorax. You have iatrogenic traumatic and then you have spontaneous. Under iatrogenic traumatic, you have things like your procedures such as central line insertion, chest drain insertion, and then you have things like rib fractures. Under spontaneous, it's further divided into two types. You have your primary and you have your secondary. The main causes for primary are things like scuba diving, smoking, Marfan syndrome, and even flying. Under secondary, you have causes which are related to the lung itself, such as asthma, COPD, bronchiectasis. So with pneumothorax, it's really important that we pick up on some clinical signs. For example, you can look at this man here who is complaining of chest pain. The patient can collapse due to hemodynamic instability. There can be unequal chest expansion. The patient can be quite breathless because there's not enough oxygen being delivered to the lungs. The lungs can sound hyperresonant, and that's basically because you're accumulating air and air sounds hyperresonant on auscultation. And you can also have reduced breath sounds on the same side because your lungs are not able to expand symmetrically. Now, the next thing is we need to be aware about tension pneumothorax. So if you have a look at this diagram here, this is basically a diagram of a healthy young gentleman. And in tension pneumothorax, the following signs are seen. And that basically happens because the pressure in the lung starts to build up so much that it starts pushing the lung away from its original side, and it also takes the trachea along with itself. So you would normally see that the trachea is deviated to the opposite side, and the patient is in quite a lot of distress, and there's signs of hemodynamic instability like hypertension, tachycardia, and even raised JVP, which happens due to the buildup of back pressure. Last but not the least, we'll be having a look at the management. Normally with pneumothorax, you do not perform a chest x-ray because that can be a life-threatening situation. However, if you do ever perform a chest x-ray, all you need to do is that have a good look at your lung markings. So if you have a look at this distance B, this is the one that we are more concerned about. And the greater the distance, the more worrying it is and more likely to be tensioning as soon as possible. And that's something that we need to keep in mind before we decide what type of management we perform. Starting with the basics, as usual, if the patient is in respiratory distress, give them high flow oxygen, 15 liters, and also make sure you're giving them a good amount of analgesia because they will be in some significant pain. And that will also help you to perform certain types of procedures to alleviate the symptoms, which I'm going to discuss in a minute. So, as you remember, there are two types of pneumothorax, which can be primary and secondary. Now, the distance B is the one that I was going to mention now. So, generally, if this distance is more than 2 centimeter for a primary pneumothorax, all you do is that you just put a needle in and you aspirate it. However, if you find that the distance is less than 2 centimeter, all you need to do is that do a chest x-ray, make sure the patient's stable, discharge them, and just review them in another 2 to 4 weeks time. Looking at secondary pneumothorax, it's a bit more different. Basically, if your distance B is more than 2 centimeter, that's when you need to insert your chest drain, and that's where your analgesia comes handy. And if it's less than 2 centimeter, you stick a needle in and you just aspirate. Now, generally, the location to insert the chest drain or the needle is the same location. It's usually the second intercostal space mid-clavicular line or the sixth intercostal space mid-axillary line. And yeah, I think that's all from my session. And thank you so much. I hope you guys found this useful. Please like and subscribe to our channel. And thank you guys so much for watching Medics Corner.